asked to moderate about targeted therapies and ALK and ROS and everything. And my first thoughts, again, as I normally say, when Sachin told me this, was, I rename this panel discussion on immunotherapy and target therapy and NSCLC. Are we spoiled for choices? So I think yes. And I would just like to have a slide saying the journey of lung cancer treatment. So these were, medical oncologists treating lung cancer, looking at the breast cancer scenarios. Somewhere in 2005 and 2006, कि मेरा number कब आएगा? And this was probably Kumar Prabhas thinking कि मेरा number कब आएगा बैंक करके. So सर का number आ गया है, everybody knows that. So this is Dr. Kumar Prabhas now actually, who has a lot of candies to look, He has a lot of pharmaceutical companies coming over there. Sir, हम हमसे ये कर लो, वो कर लो करके. So I think lung cancer का number आ गया है. The second thing which I also showed was, this was lung cancer treatment in 2007. Look at the gentleman over here. And this is the gentleman who is smiling slightly suddenly over here in 2020. So that has become the change of lung cancer treatment. So my first question goes to Dr. Shyam Agarwal. Sir, what do you think has brought about this smile on Kumar Prabhas's face?
I showed my first slide was a lot of understanding about the non-small cell lung cancer categorization has gone in, because one disease, lung cancer was one disease, then you had SCLC and non-small cell, then you had squamous and non-squamous. Now you have various targets because the drugs are available, and finally you have the PD-L1 and TMB, which are responsible for treatment for patients who don't have those targets.
So basically, it is the biomarkers basically of treating, which really has made about this change actually in lung cancer. So I thought, I will divide the biomarkers into a must-have, that is the essential biomarkers, and some nice-to-have biomarkers, that is the desirable biomarkers. So Dr. Amol, I'd like to start with you. So there are certain essential criteria, there are certain desirable criteria. So Dr. Amol, EGFR for you, EGFR, ROS and all those things, are these must-have or these nice-to-have biomarkers?
Must-have.
Must-have, all of them.
If possible, you should get the testing done upfront for most of them. If there is a financial issue or a tissue issue, at least get EGFR, ALK and ROS upfront.
So you were not impressed by my talk as usual?
No, you can, as I said, if it is possible, you should take it. BRAF is positive in 2% of patients, so yes, you should get it tested.
So for you, all of them, so again, EGFR, will you start your treatment without a BRAF?
No, we will like to know everything and then start the treatment.
Okay. Dr. Sumant, will you like to start your treatment without a MET exon 14 splicing mutation? Sumant, you have to unmute yourself.
Sorry. If you say must have, EGFR, ALK, ROS and PD-L1 in today's scenario will be my must have.
Okay. Okay, and as usual, I know people don't get impressed by my talk and all. What harm has BRAF done? BRAF has got 2% and ROS has got 1.4%. Just because I spoke about BRAF and Kumar speaks about this, that is why you're not getting impressed.
No, we are always totally impressed by you.
But you are not impressed by Novartis.
So Novartis came with a product in lockdown, so the impression will be a little lockdown.
Last, it's not a laughing matter. So let me just butt in and tell my reservations about all this. Okay. So currently, I think we've done several of these panel discussions. So we are not into, at the moment doing the NGS. So currently EGFR is being done by RT-PCR and ALK and ROS by IHC, because number one, the turnaround time for NGS is around 3 weeks. We're more expensive, so a lot of people can't afford it. And if you don't get anything out of it, then you are kind of lost only with chemo. So these are practical issues which you are facing in day-to-day practice. So which we need to convince the laboratories to really come back to us and tell us that they provide us a report. Because many times, once we have sent the NGS, we get 0 out of it.
Okay. Dr. Navneet, your take on this?
For me, you know my answer. EGFR ALK is the must-have. The next one is PDL1. And all the others are
plus minuses. Okay, Kumar, your take. I know your take, but I would like the audience to know your take on this. Yes, Kumar, Dr. Kumar.
It is like it is must for all of them. That will be my opinion. But I do understand. Looks like majority centers of EGFR comes slowly. Ross and BRAF is picking up. Others will pick up. But it is like bit like this. We want a 2-meter distance. But living in Mumbai, can I have a 2-meter distance when I go out? But it is what we want. But if you ask me in a discussion, we should have this discussion that it must have of them. That is what will lead to its implementation more and more in the clinical practice.
So, Dr. Sham, I have a point to whatever you said, sir. I mean, the point is we are anyway doing EGFR cross. I mean, why don't we switch everything to NGS?
No, I fully endorse your point. I think we are in the sort of process of shifting from those individual testing to NGS, but I think the confidence is not there somehow to go for an NGS for ALK and ROS particularly. Because, I mean, I don't know, I'm somehow, there's lack of communication between the lab people and us now because of the COVID, because these people are coming so regularly. So there's a little, in my mind at least, there is a little, a black box there, which doesn't permit me to send all my samples for NGS.
Okay,
Ullas, coming back to the NGS issue, sorry, I'm cutting you short. Coming back to the NGS issue, again, the problem with the NGS is so many labs coming with so many NGS panels, especially in lung. Again, the authenticity and other issues. See, in RDCI, you have your at least paneled NGS things. In the private practice, so many NGS panels are there, so many other issues are there. So I don't know. We are much happier with those ARM, Scorpio, EGFR, and all those things. I don't know. NGS
there are trust issues with the laboratories. You don't know whether the quantity of DNA was nice, whether the way they have reported that was nice or not.
So NGS, I think we are still not very comfortable.
Okay.
So I want to ask the panelists that
I am the moderator. You will answer. I am the moderator. You will answer. So what stops you from sending NGS?
Let him ask.
What stops you?
The problem with NGS is that we don't know what is the standard lab. Can you hear me? Hello. So the problem with the NGS is that we don't know which is the standard lab. Say for example, in Bombay, I know for IFC standard is Anita Borges lab, and I sample to her, I get a fantastic result. What about the test? Where to send? Unless I know that, say that Tata is doing everything, or maybe another good lab is doing everything, I will send.
Okay, so there are trust issues basically. So tomorrow, if Anita Borges Madam Lab starts doing NGS, we all will be very confident we will start doing sending it over there.
Yes, yes.
So the problem lies with Anita Borges Madam and not with us.
No.
Yes.
Ullas, cost is also an issue.
Cost is an issue.
If it is 30,000 rupees, I don't think a lot of people can afford it.
Sir, but the point is, even with EGFR, we are sending about 20,000 rupees. If we send sequential, BRAF and all, it will become more only, no, sir?
These three are available free of cost today from, co-patient kind of a protocol.
Okay.
So we'll be free of cost.
Sir, but my point over here, there are a lot of people who said about the trust issues, but there are not many labs who do EGFR alcohols. That also we kind of do it from external lab only, no?
Yeah, Ullas, sorry for interjecting. So we actually need, the same tissue biopsy should be sent to one lab which does everything in a reasonable cost. That is what we want. Here what we are doing is we are first doing biopsy, they are doing ISC, then the tissue gets exhausted, then we want PDL1 also, we want EGFR also, the tissue has to be, used sequentially.
Okay.
Some labs are doing NGS, they are not doing PDL1. The specialized lab, they are refusing to do PDL1 or they are outsourcing to somewhere else.
See, ultimately the point is we all want, but we are not able to get because of logistics issue. But yes. I think in time we need to convince ourselves, at least I am now convinced in my mind that you need to probably, ultimately you will need to have EGFR, AL, ROS, and everything coming over. I mean, you need to have an NGS. Dr. Kumar, do you want to come in?
One of the aspects is that this is a bit of our training, the way we are trained. Our understanding of NGS is lacking. I think so. We do have some wonderful labs in this country. I assure you that they do outsourcing work for many of those world-class companies which comes here. So there are some wonderful labs in this country. So it's not like we don't have. I do agree there are many of them which come to problem disease which are good, but that is where we need to have a discussion. An open forum is not nice to take the name of the lab, but there are many of them which are world class and we can rely upon the result. But second part, more important, is our understanding. We understand fish more because we have been using this almost for decades and more than that. IHC we understand far better and we communicate with our pathologists far better. That communication is lacking today with our molecular biologists because our regular pathologists, they are not able to communicate and we are not able to communicate NGS report with them because when we ask questions to them, they are not able to give you the right answer. For example, someone said you in situ and put the technology. Any technology you take, you will have those small differences. You will have 1% to 2% difference between ISC and fish. But that we trust one of them. So those understanding till what time you need to wait, till what the data you need to take it for clinical practice, and those questions. What is those alleles? What is those percentage of alleles? What is the DNA quantity required? That dialogue and our understanding has to be there a little. Unless we have that, this idea that NGS is bad will continue.
So my point over here is totally agree with Kumar. And I think one thing which they have started is a molecular tumor board in the hospital, which we are also doing in our hospital. We are going to start this chart shop thing. You need to talk to them because it's a new thing. But trust me, I mean, having gone through all the panels, whether we like it or not, you're going to adopt to NGS in some time. In 5 years' time, you need to have NGS on your watch. So that is going on. I think we'll just move on because we have something more to discuss. Okay, so this I think liquid biopsy, Dr. Navneet, must have or nice to have?
Liquid biopsy depends upon the scenario. I think that is something that is going to be soon must have, maybe in the next few years to come or even earlier few months also.
Okay. Dr. Shyam, sir, liquid biopsy and tumor mutation burden, must have, nice to have, don't want.
So, I think, what we are doing today is, as we said, we are doing RT-PCR and IHC. Okay, so if you have the tissue and all those three are negative, then I think you can go for next generation sequencing because there is a 10 to 15% additional pickup rate for those genes which have turned negative on IHC and RT-PCR. So I definitely like to do that. Tumor mutation burden carries no meaning at this point in time, by and large in the practice. But I think NGS, either by the tissue or liquid biopsy, does have a meaning if some can afford.
Okay. So the next question is for Sachin Gupta. Dr. Sachin, are you still here? Sachin?
Yes.
So this guy must have or nice to have?
I'm still
So this guy is definitely a must to have, right?
So for me, I would love to have, NGS definitely. TMB is again, let there be more information how to use it. I'm still not, I still don't know how to use this in practice and where to integrate it and how to integrate it.
Okay, we'll just go ahead now. We will just go ahead now, Sachin. So again, we all know Dr. Kumar Prabhash's thought on EGFR mutant lung cancer. So let me start with Dr. Amol. Dr. Amol, what is your first line of choice in EGFR mutant non-small cell lung cancer in a real world? Let's not talk about an ideal world scenario. Let's talk about what you actually do.
Bangladesh best osimertinib.
Osimertinib. And how many people in the last 1 year have you given first line osimertinib?
You have not heard me properly. It is Bangladesh best osimertinib.
Bangladeshi osimertinib. Okay. Okay. Dr. Navneet?
Hello.
Yeah, Dr. Navneet.
Yes. Sorry, I missed the question.
So what is your treatment option in first line EGFR mutant non-small cell lung cancer, first line therapy? Your choice, a real world scenario, not an ideal world scenario. What do you normally do?
Real world scenario, most people will end up getting a single TKI. That would vary. Most of them would again get first generation TKI just because of the cost.
Okay. Dr. Amol said Bangladeshi osimertinib. I am not going to discuss that right now.
We shouldn't.
Said first and second generation. Okay.
Ullas, 1 minute.
Yes.
We should not be talking of offering somebody an illegal version of osimertinib when you have alternatives available. It's a different scenario when you have a person who has progressed on a first or second generation TKI and a T790M positive. That's entirely different. It can't afford the regular osimertinib.
Point well taken. Point well taken, Amol. Okay.
Yes.
We will not discuss this. Dr. Shyam sir, in your practice?
Yeah, it's mostly a single TKI. People can't afford osimertinib most of the times, 90-95%. So they either go on a drug like afatinib, or if they can't afford that, then it is first generation. Which
okay,
is
Sumant, I missed you somewhere in between. Sumant is still here? I think he's got disconnected. So Dr. Kumar.
Real life scenario.
Real life scenario.
Beyond gefitinib and erlotinib, choose one of them. And in my practice, absolutely legal TKI plus chemotherapy, that is gefitinib plus chemotherapy. I'll add to it, I saw some discussion on it. So do we treat even sarcoma giving VIE for 7-8% survival benefit? Do we use as taxane to AC for 3 to 4% survival benefit? I assure you, combine this drug and the toxicity will be not higher than this, and benefit remains similar. But I do concede there are 4 options in that setting. You choose one of them. But in today's time, we do have an option beyond gefitinib and erlotinib, options where you can add life to the patient. And if we give only these treatments, we are giving an inferior treatment to the patient.
So I think I would agree with Dr. Kumar and said, this is exactly what a non-small cell lung cancer, this is the girl over here is actually the non-small cell lung cancer. There are a lot of suitors for her, I actually wanted to put a Rakshika Swayamvar photograph over here, but then I thought it was politically incorrect. So I put this snap over here. Probably and this is the OS benefit, and now in EGFR mutant non-small cell lung cancer, we are talking about the FLORA trial, the Archer trial, our own TMS trial, NEGA trial, which has shown an OS advantage. So definitely for all of us who are listening, we should at least start to go beyond the first and second generation TKIs actually, and maybe it could be the osimertinib or a EGFR TKI combination or sequential therapy. But in my personal opinion, the only treatment with EGFR first line is the first agent is not really optimal. Add something to it. Because as Kumar said, we are on to 3 years, 4 years, we may just become a bit more with that. So we don't know. There are many choices. It can be a yes, no, maybe, depending on whether we live in an ideal world scenario. So what about ALK rearranged non-small cell lung cancer? We'll go to Dr. Shyam Agarwal first. Sir, in a real world scenario and an ideal world scenario, both.
So what is your question?
So your question is on the screen, sir. What is the is it settled? Your first line choice of treatment.
Okay, for ALK positive.
So
alectinib offers you the best outcome, which patients cannot afford. So short of that, I think either crizo or ceritinib.
So which one do you prefer, sir? Either crizo or ceritinib?
I don't have much to choose between the two.
Okay. So alectinib if you can, otherwise give whatever over there. Okay, fine. Dr. Amol?
Yeah, I agree with sir.
Okay, Dr. Navneet?
So for brain penetration, I think ceritinib would have better penetration, right? Alectinib would be the best. So I would choose ceritinib if alectinib, because of the cost issues, is most of the times we are not able to give.
Okay, Navneet?
So if you're talking of, again, if you want real world choices, Then if a person has a BPL card, he gets crizotinib free.
Okay.
If he does not have a BPL card but still is not very well to do, then the choice is seratinib, just because the monthly cost of therapy is close to 30K and even lower with the Indian drug.
Don't mention that word. Okay.
No, it is allowed. They have the court approval to sell it.
Okay. Then it's okay. Okay. Kumar?
So ideal, I'm sure everyone agreed, alectinib. Real world, either crizotinib, seratinib. We do more crizotinib because, again, mentioned by Dr. Navneet, we get our 65% of the patient free, and we just analyze our data. The median survival is around 40 months odd with the crizotinib sequentially giving other treatment. So we are pretty comfortable with it, but then also I would have preferred alectinib, but only very few patients can take it.
Okay. So this is what the EGFR efficacy was, and if you look at it, the global ELIX said 34.8 months PFS, and the intracranial overall response rate, as we all were saying, was in ASCENT for 73, 81, 78%. So I mean, in ALK, I think 5 years survival with alectinib was 64%, and 5 years survival with crizotinib, I think median PFS was 57.5 months. So that was fantastic.
So, we have to stop.
Just last one. Mm-hmm. So this is the alectinib, I think, in the front with everybody else in behind. But whether you can afford that guy or not, we don't know. Can I have just 2 minutes, Sachin? Last this thing? Or we have
30
last 2
seconds
minutes.
and 30 seconds.
So immunotherapy, non-small cell lung cancer, forget about it. So Dr. Kumar, less than PD-L1 0%. Let's get to the meat of the discussion. Will you give immunotherapy? No. If yes, which one? Dr. Kumar, unmute yourself. Yeah.
I'll prefer giving it. I want to wait in the second line, but I end up waiting. But having said that, I'll prefer giving it, and I'll prefer giving it pembrolizumab in combination.
Okay, Dr. Amol?
But I do understand the other option.
You will give.
If it is less than 1%, there is no choice but to give it in combination.
Dr. Navneet, will you give it?
Yes, we are assuming they're all driver negative, right?
Yeah, all driver negative.
So there is no doubt. It is a combo.
You will give IO chemo combo. Dr. Shyam, sir?
I think there's no need to do the PDL1 today.
He's in a mood to smash.
Let me be provocative. And, just look for driver mutations if they are not there. Combine it with your, if it is non-squamous, I think Atezo can be used with the 3 drugs. And if it is squamous, then Pembro with, with KIT.
Okay. So Sumant, your take?
Immuno with the Immuno. But why is everyone forgetting the old baby which never said to do PDL1?
Okay, we will come to that later. I think we will just go on over there. This is my last slide, and I always used to keep hope as my last slide, but I think lung cancer deserves a cure too, and definitely in next year, maybe next year, we are going to have a lung cancer survivors meeting, Dr. Kumar Pravash, with you leading front over from here. So thank you, Sachin, for